Good morning, everybody. This is Mrs. Franson again, and this is part 3 of Chapter 14, Depressive Disorders. This particular lecture, we're going to talk about some alternative treatments for severe depression, and we're going to begin by talking about electroconvulsive therapy, or ECT. ECT is a highly effective treatment that's been misunderstood by the public and misportrayed by the media for many years. It can be a first-line treatment in rare circumstances. For example, the suicidal or homicidal patient who needs rapid, definitive response for safety reasons. It can also be used for other patients. For example, patients who don't respond to traditional antidepressants, or patients who have marked symptoms like agitation, vegetative symptoms, or catatonia, the patient with psychotic features or hallucinations. It can also be used by manic patients who are not responding to lithium or other drugs, or by the bipolar patient with rapid cycling, where they're moving quickly between mania and depression. It's even used by schizophrenic patients. And it can be used by pregnant women who are severely depressed during pregnancy, including the first trimester. Now, no one really understands how it works, but recent research indicates that it enhances the effects of neurotransmitters such as serotonin, dopamine, and norepinephrine. It also has a very high success rate. Just to let you know, it is a very effective treatment. It's not at all the way that it's portrayed in the movies. It's not a one-time event. The patient has to have 2 to 3 treatments a week, and then however many treatments they'll have, it will be determined by the severity of their illness, but many patients get between 6 and 12 treatments. It does cause cardiac stress, so patients have to be very carefully evaluated. It can be given as a voluntary or an involuntary treatment. When would we use it involuntarily? On a patient, maybe on someone who was homicidal and a great danger to others, or to a severely incapacitated depressive patient that was incapable of making their own decision. When we do it, the patient is given general anesthesia, they're given a muscle paralyzing agent, and they're intubated during the procedure. A brief grand mal seizure does occur, but it usually only lasts from, say, 10 to 60 seconds. When the patient recovers, they may be confused and disoriented for several hours after the procedure, and this procedure is usually done early in the morning after 8 hours of fasting. Of course, you'd want to carefully assess any patient with a history of hypertension, congestive heart failure, cardiac arrhythmia, or any other cardiac condition. Patients may have memory loss even up to a few weeks after the procedure. Although it's highly effective, it is not a cure for depression, and these patients will have to still use antidepressants, or they will have to use maintenance ECT to avoid a relapse. There's no absolute contraindication for this treatment, but there are patients you have to be very careful with, and we've already talked about the cardiac patient, including someone who's had a recent MI. Some other very touchy situations would be doing this on a patient that has had a stroke or a CVA, or a patient that you know of that has a cerebrovascular malformation in the brain, or some type of intracranial mass lesion. So let's talk about some nursing responsibilities and concerns in this situation. You would want to definitely check for the informed consent that the doctor would do with the patient. You'd want to make sure your patient understood what to expect and what was going to happen and what the potential for improvement would be. You'd want to check and see if any medications that affect the patient's seizure threshold have been decreased or stopped several days before the procedure. So what drugs affect a seizure threshold? Obviously, anti-seizure medication, but also some of the antipsychotic medications affect seizure threshold too. Two drugs that need to be stopped at least 2 weeks in advance are any MAOI antidepressant that they're taking and the drug lithium. You'd also want to make sure their hypertension was controlled before the procedure. And the nurse is the person who's going to be monitoring vital signs and mental status before, during, and after this procedure. 30 minutes before you start, you give the patient atropine or robenol to decrease secretions and to decrease the vagal response. And I'm going to remind you that the vagal response means the patient's blood pressure and heart rate will drop. Now, once this has been done, this patient needs the same level of care and observation as a person coming out of surgery would need. So they're going to need close monitoring, and you'll need to provide frequent orientation. One complaint we get from patients who've had this procedure is that they have, as side effects, a headache, muscle soreness, and nausea. Some other treatments I'd like you to know about are the transcranial magnetic stimulation. This is very promising and has helped many patients already. To do it, they use an MRI strength magnetic pulse, and it stimulates the cerebral cortex. The great thing about this is it can be used during pregnancy, so it's a good choice for a pregnant woman who's severely depressed, and it can also be used without the use of antidepressant drugs. The one side effect that needs to be monitored after the treatment is patients often have a headache. The other problem with this is it takes a long time, like several weeks, to be effective, but it does work. Another thing you may read about in your textbook is the vagus nerve stimulation. This is invasive. It's a pacemaker-like device that's inserted in the throat, and it releases a pulse every 5 minutes, 24 hours a day. And it does decrease depression, but it alters the voice of people in 60% of our patients. So it is not used very often for that reason. Deep vein stimulation is very invasive because electrodes are surgically implanted in the brain. It used to be used to treat depression, but now it is mainly used to treat Parkinson's disease. Light therapy is very important to know about. You may remember from part 1 of this lecture that it is the first line treatment of seasonal affective disorder. So remember that people living in very northern locations where they have a few hours only of sunlight during the winter are very prone to seasonal affective disorder, and light therapy is our #1 treatment for that. Now, let's talk about a couple of alternative treatments. Many patients buy St. John's wort over the counter to treat their depression. Does it work or doesn't it work? Research shows that in many cases it does increase serotonin, norepinephrine, and dopamine, and that it is effective for mild to moderate depression. Another alternative therapy that you really want to encourage your patients to participate in is exercise. We know that exercise increases the levels of serotonin, and it definitely improves the symptoms of depression. Advanced practice interventions are those interventions that are directed by advanced practice nurses. So I'm just going to use this slide as a review. Let's talk for just a minute about cognitive behavioral therapy. Remember that cognitive behavioral therapy is therapy directed at helping the patient change their negative thoughts because their thoughts directly relate to their behavior, and their thoughts and behavior directly relate to their mood and level of depression. So that's what we're doing there. And now we're going to go over some review questions. A patient with major depression walks and moves slowly. So how are you going to describe this? Hopefully you see that that would be psychomotor retardation. Which assessment finding in a patient with major depression represents a vegetative sign? The answer would be hypersomnia. The vegetative signs have to do with staying alive. So sleep, eat, eliminate, and have sex. Hypersomnia means the patient is sleeping too much. Hyposomnia would mean they couldn't sleep, they couldn't get enough sleep. Which question would be a priority when assessing for symptoms of major depression? Pick the question that directly relates to mood and depression, and that would be question B. You look really sad. Have you ever thought about harming yourself? If you suspect a patient has potential for suicide, do not be shy, ask them. Your patient was just diagnosed with major depressive disorder. What medication do you anticipate the healthcare provider will start the patient on? Hopefully you know the answer to this because we're always going to start with selective serotonin reuptake inhibitors as first-line therapy because we know that they are the safest drug to start the vast majority of depressed patients on. What are the side effects? What side effects might the patient experience? Hopefully you know this too. The main one that patients complain about is sexual dysfunction because it messes up their ability to have orgasm. And don't forget that this particular class of medication causes other side effects which are listed on the slide. Good luck on your exam, and let me know if I can help you in any way. Have a good day.